So we're delighted to have Preet give us a talk today. Dr. Shaikh began her training at Aga Khan University in Karachi, Pakistan, before coming to Washington University for an away rotation, and then came here for residency, where she is part of our teaching physician pathway. While in Pakistan, she worked with the underserved population in Karachi, including some documentary filmmaking, highlighting healthcare disparities and corruption in the public health sector there. We are really excited to have her talk today on myocardial infarction with non-obstructive coronary arteries and coronary microvascular disease. Just working with Preet, personally, I can say she is a fierce advocate for her patients, and really excited for her to give this presentation.
Hi, good morning, everyone. Josh, that was an awesome presentation. Thank you, everyone, for being here. Thank you, Dr. Sislo and Dr. Costco, for inviting me. Today, I'm going to be talking about coronary microvascular disease, or CMVD. Just as a primer, this also covers MINOCA, INOCA, and we'll talk about these definitions a little later in my talk. I have no financial disclosures. So today we're going to start by discussing a case and then discuss the statement of the problem. I will go over and illustrate some coronary artery anatomy. I will then review the physiology and pathophysiology of microvascular dysfunction. I'm then going to describe coronary microvascular disease as it results from those dysfunctions. We're going to highlight some landmark studies that brought attention to the disease. I'm going to give examples that emphasize its implication in clinical practice and briefly discuss diagnosis and management. At the end, my goal is to convince you to put this disease on our differential when assessing people with chest pain in the office or in any clinical setting. This is a case that we've all seen in the ER, in our office, maybe in the wards at times when we're called for an ACT. This is a 41-year-old lady with a past medical history of hypertension, GERD, anxiety, who presented to probably the ER with 2 weeks of exertional left-sided chest pain. Her EKG showed a millimeter ST depressions in leads 2, 3, and AVF. Her high sensitivity trope was elevated to 192, peaked at 214, and then came down at next check. The normal high sensitivity trope is -4 or less than 4, I should say. This patient continues to have unrelenting chest pain. She's made NPO for a coronary angiogram, which we all know as a gold standard of cardiac testing as far as ischemia goes. This is done the next morning, and it reveals a 20% occlusion in her RCA, a 30% occlusion in the LAD, and 20% occlusion in the left circumflex. To those of us who may not recall, this is likely a non-obstructive coronary artery disease pattern. This is not a very concerning coronary angiogram. The question, though, that I want you all to think about is, despite this angiogram, can this patient's chest pain still be due to ischemia? Now, chest pain is a thing we've all seen on nights, on calls, even when a family member calls us and tells us they have it. What do we all imagine when we imagine a patient with chest pain? Probably something like this. or like this, or even like this. Now, what do these three people have in common? Probably the same acting coach, probably the same person who painted their walls. And they're all, they're all men. This is the Hollywood heart attack. This is what we imagine when we imagine a heart attack. Now, believe it or not, to get these pictures or to get a picture of a woman with chest pain, I had to go to the third page on a Google search. Most of us studied this being the regular common garden variety heart attack. We imagine a man with a heart attack. But recent studies have showed that the numbers don't quite add up. So what is the problem today? In the US, 190,000 women are dying of ischemic heart disease every year. Not just heart disease, ischemic heart disease. Since 1984, more women than men have died of ischemic heart disease every single year. It continues to be the leading killer of women of all ages. It has a higher annual mortality than all cancers combined, and it even has a higher annual mortality than our most common cancer, breast cancer. It has a higher 30-day mortality if a woman is seen with ACS in the ER compared to a man. And the crux is, over 50% of these women, when evaluated with a coronary angiogram, actually have non-obstructive CAD. They have a less than 50% occlusion in any of their arteries. We don't find a culprit artery. Let's look at this graph here. So this is a graph that shows how mortality has changed over the last, or between 1980 to 1998. On the x-axis, we see the cumulative percent change in mortality rate. As it goes down, this is good. On the y-axis, we see a function of time, or the year, and it starts from 1980 and it goes all the way to 1998. There's three curves that I want us to look at. The bottommost curve is males. The middle curve here that's dotted with an X is white females, and the topmost curve is Black females. And what do we see here? We see a few things. One is that mortality has continued to go down. This is really good. It's reassuring. And things have happened on the way to make that happen, but overall, this is a good thing. We also see that even though mortality has decreased for all three demographics, the most precipitous drop has been the men. And we've seen, if you look closely here, that the gap is actually widening. Men have reached all the way over here. They've reduced their mortality or chances of mortality rate by 50%. And the women are really lagging behind, and Black women are even behind white women. And then we see a final third thing when we look at some of these studies. We see that there's very clear paradoxical sex differences. Women have less anatomically obstructive CAD. They have more chances of a preserved LV function, and yet they continue to have greater rates of myocardial ischemia, mortality compared to men who are the same age and have the same textbook risk factors. Based on this information, it is not a stretch to conclude that another disease process is likely at play here. And importantly, till we describe and recognize this disease process unequivocally, we are far from having evidence-based clinical guidelines to guide therapies and management for this important patient population. I will now go over coronary artery circulation. So the coronary vasculature is complex, but simply put, there's three major compartments. You've got your three big, large, stentable epicardial arteries. They run on the surface of the heart. They're anywhere between 500 microns and 5 millimeters in diameter. So they're still pretty small, but they're large enough that we've devised ways to see them. And they're still larger than millions of other vessels in the heart. We recognize these vessels. This is your RCA, this is your LAD, this is your left circ that people report after angiogram. These vessels carry blood, but their intrinsic properties do not allow them to change blood flow by very much. Physiologically, they're relatively quiet. But that's not it. We have 95% more vessels in our heart that are microvessels. We can't see them. These are the prearterioles and the arterioles, so they're right about over here. And they actually make up the bulk of the myocardial vasculature, and they have a very important role to play. The prearterioles maintain pressure as blood passes through, but it's the arterioles that I really want to talk about here. They're responsive to the metabolites in the environment. These arterioles are at max 100 microns in diameter, but they're intramural. And the beautiful thing about them is they can change their diameter based on what the heart needs. And this function of the heart to adjust based on what you and I need, based on our stress levels, based on exercise, that's actually a really important key parameter in what it does. And the fact that these arterioles can constrict, they can dilate, and they can adjust by doing these actions flow to match myocardial demand is really key. This ability to match flow to demand is known as blood flow reserve, and it is a crucial characteristic of the coronary microvasculature. And also, it has mechanistic implications for coronary microvascular dysfunction. And we'll return to this concept a little later in my talk. But I just want to look at the conductive arteries or the epicardial arteries here. They are not responsive at all to what's happening. But if you go and look at the arterioles, they are very responsive to what's happening, and that's important. But why does this matter? How is this killing people? How is this affecting morbidity? For the last 50 years, we've been studying coronary artery disease from the same lens. We are focused on these big, large, stentable epicardial vessels. And this is also known as obstructive CAD. And while this is important, over the last 20 or so years, the focus, if it hasn't shifted, it's definitely expanded. And we're now beginning to think about the myriad dysfunctions that can happen in our prearterioles and importantly, arterioles. We're starting to think about microvasculature dysfunction and we're giving it due respect. And we're seeing how this can cause coronary microvascular disease or is the precursor to coronary microvascular disease. The pathophysiology of microvascular dysfunction is pretty well delineated now over the last 20 years. You can have obstruction, infiltration, you can have vascular remodeling, rarefaction, you can have fibrosis, dysfunction of the smooth muscle lining, endothelial lining, you can have extramural compression, reduction in diastolic perfusion time. As you can see in the top image, there is a microvascular emboli here. So microvessels, microvascular problems. So this is a microemboli. This was seen in a patient on an autopsy. The patient came with ACS. They had a negative coronary angiogram and they still passed a few hours later. This is an MRI image. The star shows late gadolinium enhancement, likely showing microvascular dysfunction in this hypointense zone. So what really comes under this big bucket of CMVD? A lot of my mentors studied this as cardiac syndrome X when they were in med school. A lot of us think this is synonymous with MINOCA or INOCA, or a lot of us really don't know what this is. And admittedly, I learned a lot through researching this topic, but CMVD is the big bucket that we can probably put all these terms under. We don't have a consistent definition across literature, or we are now only starting to see one, but frequently we're seeing that CMVD has been described in the ways it clinically manifests. So if a person comes in with a big MI and there were no obstructive arteries, that's MINOCA. If a person has stable angina symptoms and no obstructive coronary artery disease, that's probably ANOCA. It was first described by Kemp in '73, patients with typical angina, ischemic and biomarker elevations of CKMB probably at that time, without obstructive CAD. Now we know that this is probably related to microvascular dysfunction as we saw in the previous slide. And we can probably mechanistically implicate coronary flow reserve here. So what is coronary flow reserve? It's an equation that basically measures coronary blood flow at maximal dilatation divided by coronary blood flow at baseline. So normal is greater than 2, and less than 2 is pretty grossly abnormal, and that's what we're using in most of our studies. And we now, fortunately, have really good ways of measuring this, both invasively and almost surrogate for this is a very good non-invasive measurement by MRI. One caveat here that I want to bring up is that epicardial CAD will affect coronary flow, but most of us will probably be considering CMVD after ruling out CAD by angiogram. So that confounding should really not play a role here. Over the last 20, 30 years, really brilliant people have come up with really good ways to measure this. And our ability to measure this allows us to diagnose this. We can use both invasive and non-invasive measures to do this, and we'll go over these briefly later. And there's actually been growing interest in this condition, but the attention to CMVD was largely driven by several landmark studies that came out in the late 90s, early 2000s, early 2010s. One such study was the Women's Ischemia Syndrome Evaluation. It was led by Dr. Mertz. She showed that abnormal coronary microvascular dysfunction is associated with adverse clinical events. So what was the WISE initiative? So there were 936 women that they picked who had presented to the ER with angina or chest pain. All of these women underwent a coronary angiogram to evaluate for signs of ischemia. And the results were pretty impressive. After being followed for 9.5 years, 1 in every 5 women assessed for chest pain in that ER and got that coronary angiogram died within 9.5 years. 2/3 or almost 2/3 of deaths were cardiac. Of the women who died of a cardiac cause, 1 in 3 actually had a clean or negative coronary angiogram. And these are pretty big findings, right? This study shows evidence that most of the things that we use to reassure ourselves are probably premature. We know that most of the predictors of mortality continue to be risk factors that can be modified by current therapies. It's not a plaque that you can probably do not very much about. It's a plaque that probably is developing on a level that you can't even see. This further supports development of clinical trials in women symptomatic of ischemic heart disease, even in the absence of obstructive coronary artery disease. And even though the WISE initiative really highlighted the prevalence of CMVD in women, we find that maybe the story really isn't so different in men. So as we see here, this graph shows a few things. On the y-axis, you can see MACE, or major adverse cardiovascular event. This is, things like strokes, heart attacks, heart failure, hospitalizations, bad things that can be attributed to cardiac disease, essentially. On the x-axis, you see years, and these people were followed for about 3 years in this study. So what did Dr. Murdy show? She showed that the dotted line here, which shows people with good coronary flow reserve, so people who probably don't have bad coronary microvascular dysfunction, men and women do very similarly as far as MACE goes, and actually don't do so bad. And what do we see in this continuous line up top here? We see that men, which is blue, and women, which is red, again, do very similarly. These curves barely separate, and if anything, men take over. But also, they had a way higher chance of MACE events and earlier than people without a low CFR. A Danish study has similar findings. 11,000 Danish patients were enrolled. They had a coronary angiogram. 2 important findings came out of this study. Significantly more women than men had non-obstructive CAD, and the numbers were big. It was 65% versus 32%. And these patients, even if they had non-obstructive coronary artery disease on angiogram, had higher bad MACE events compared to the cohort or the general population that did not have angina. And there's growing interest in this condition. We're seeing more and more studies, more and more papers come out, this last one at WashU. And there's clinical implications here. Mechanistically, we see that there's growing evidence that CMVD is a precursor condition of HFpEF. We see that COVID-19 myocardial injury is probably related in a large part to CMVD. We see evidence that cocaine-induced ischemia and ACS presentations, hypertrophic cardiomyopathy, all of these have a big element of CMVD. We see that it contributes, based on the last studies, that morbidity to morbidity and mortality. And we see the great thing here is that it's not all experimental anymore. Cardiac MR is available at many heart and academic centers. We see that this disease and this diagnosis is now accessible to clinicians and by extension, accessible to patients. Let's go over these graphs here that show how CMVD is implicated in HFpEF. Let's focus on the graph on the left here. On the y-axis, it's for MACE events, and on the y-axis, you see freedom from event. The lower, the quicker you go low, basically, the bad it is, the worse it is. On the horizontal axis, you see days, so this is a function of time. The dotted line here is CFR less than 2, so CMVD, and the straight line here is CFR above 2, so probably no CMVD. And as we see here, the curves separate very early. The dotted line is less free from events and quicker. So this was a HFpEF population, and these people are quick to reach MACE events. And we saw a similar thing here for hospitalizations. So the Y and X axis are the same, and the dotted line, which is CMVD, shows us that these people have less freedom from events. We saw something similar and interested in a COVID-19 study that came out earlier this year. So what did Dracos show? They showed that coronary sinus flow at rest, which is also a bad thing and can prognosticate for early CMVD or coronary microvascular dysfunction, was highest in people with COVID. So the y-axis here is coronary sinus flow. The x-axis is part of the cardiac cycle. And the red curve here is COVID patients, and the blue curve here is control patients. At rest, we saw that COVID patients had a higher CSF. Not good. Conversely, we saw at stress, which is when you want your flow to be highest, which is when you want your reserve to kick in, COVID patients did the worst and controls did the best. This small study shows that at least in some part, CMVD can be implicated in COVID and post-COVID patients. And actually, when they followed people recovering from COVID, those who still had symptoms after several months, their recovery or freedom from symptoms was related to their coronary flow reserve and these curves. All of these studies were done by MR and they were completely non-invasive, which was pretty exciting. So what is the diagnostic approach to CMVD? There's no major guidelines, and expert consensus suggests that we should put it on the differential first and foremost. We should then empirically treat these patients with baby aspirin, statins, ACEs, ARBs, beta blockers, calcium channel blockers, depending on whether we're going for symptom control. If there's no improvement, we should assess coronary flow reserve non-invasively through MR, PET. If the diagnosis is still not confirmed, we should invasively test these patients in the cath lab. Here's a little bit on how cardiac MR can be used in CMVD. A here is normal myocardium. You see equal enhancement in the right ventricle and the left ventricle. B here is a band-like hypoenhancement. It could be microvascular, but it's probably macrovascular epicardial disease just because of how diffuse and transmural the infarcted area is. And C here is a tiny sliver of hypoenhancement. This is the fact that it doesn't spread across the wall, and some equations that our really smart radiologists can do shows that this is probably attributed to microvascular dysfunction. So let's go back to our case, our lady who had that negative coronary angiogram. The question I wanted us to think about was whether her chest pain could still be ischemic in etiology. And the truth is, without doing all of these other tests, without ruling out microvascular disease, we can't say that it's not ischemic. Absolutely, her pain can be ischemic. She can certainly have other etiologies, but the idea here is that the workup is complete by this gold standard coronary angiogram is probably not correct anymore. So what are the next steps for our patient? We need to risk stratify her by ordering LDL, A1C, by getting a thorough family and social history. Remember the two studies we talked about earlier? She is already at higher risk than the general population. 1 in 5 women like her, when followed for 10 years, were dead. We need to discuss with this patient that she may still have coronary microvascular disease. We need to discuss with her that she remains at a high risk for adverse cardiovascular events and for mortality. We need to start these really important drugs like statin and aspirin at discharge. And we need to ensure follow-up with a cardiologist in addition to a primary care doctor. So much of what we do in medicine is risk stratification. Every day we make hundreds of decisions based on the likelihood of harm, benefit, morbidity, mortality. Based on what we know or what we don't know, we can't in good conscience tell this lady she has nothing to worry about. We can't say assessment and plan non-cardiac chest pain, probably gas. Because the truth is, we know enough now to know that her risk is not the same as the general population. We know that in 1,000 women like her or 11,000 women like her, the outcomes weren't so good. And we need to know that the conversation is evolving with her from primary prevention to secondary prevention. And this isn't me being dramatic or these scientists overreacting. This is both accurate and also provides important validation to many patients whose chest pain is non-cardiac. And in this lady who has chest pain, we need to be taking her seriously. These are the treatment strategies I already highlighted. The important part here is referral to a cardiologist. So CMVD increasingly recognized as a cause of ischemia in both women and men. CFR allows for diagnosis of CMVD. We don't know the current best treatment. And here are some future directions. We need a uniform definition. We need to transition to routine assessment of coronary dysfunction or microvascular dysfunction on cardiac imaging. And we definitely need longitudinal studies of both patients and therapies. Learning about female physiology is going to help both women and men. Here are my references, and here are all the important people I'd like to thank. Thank you especially to Dr. Javaheri and Dr. Garati, who gave me time and mentorship throughout the project. Dr. Zhang, Smith, and Cooper, who made it their mission to make me a cardiologist. Dr. Kuklich, Dr. Cates, Dr. Sislo, Dr. Costco, Dr. Frazier, the chief residents, my co-residents, and my family.